Hi, I'm Colin Hung with Healthcare IT Today, where we explore the latest trends and interesting stories in health IT. On this episode, we're going to talk about RCM optimization and how it helped an organization during a very difficult personnel transition. With me today is Dr. Brian Stratta, Interim Chief Executive Officer and Chief Medical Officer of the Hyndman Area Health Centers. Dr. Stratta, welcome to the program.
Thank you, Colin. I appreciate being here.
Now, before we dive into the questions I want to ask you about RCM, can you give our audience a little overview of your organization?
Absolutely. Hyndman Area Health Center, everybody says Hyndman, which is fine because that's okay too.
I apologize.
No worries. It's a very small town located just north of Cumberland, Maryland, literally right across the border into Pennsylvania. And I mean small, maybe about 800 people. The organization started in the early 70s after a major flood hit the town. And FEMA came in because of disaster relief, set up 2 trailers on the site where our brick and mortar building's at currently to help those residents recover from that episode. And they put in a dentist and a doctor, and they ran with that for several years, actually about 20 years. Early 2000s, they went and got the FQHC award. Tried to move up into Bedford, smaller town north of Hyndman. Failed initially, but was successful the second time around. It was Bedford and Hyndman Health Centers for quite some time. My former CEO and myself came on about the same time, about 3.5 years ago, and we both had the vision of we want to expand our footprint. We want to make sure we get out there to help other people in the area.
Okay.
We're in a community, it's rural, the South Central and a little bit further west, it's extremely rural. A beautiful area, but not a lot of services out there. So we expanded up into Cumberland County, which was a little northwest of us, and then we expanded into another office into east of Bedford.
Okay.
And we're looking at expanding again into Cumberland and Johnstown, another area that's incredibly hard hit by underserved and uninsured patients. And that hopefully will be in the next year. We do family medicine, base is family medicine, but a lot of extra services, behavioral health, dermatology. I like to do dermatology procedures. Occupational health and occupational medicine, that's work comp injuries, DOT physicals, telemedicine, which everybody does now because of COVID. Thank you very much. Also the MAT program, the medication assisted treatment program, the opioid dependency and alcoholism. And our behavioral health program, I've just hired a clinical psychologist doctorate who's, she's going to expand this program greatly, and we need it. There is such a huge need for mental health in our area, and they can't get into a psychiatrist or counselor for months, which mental health goes, you don't have that kind of time frame. So I'm really looking forward to that expanding.
Now, FQHCs, you're all extremely resourceful. You have to be, just given to deliver all the services that you have under one roof and with all the different restrictions and grants and things that you have.
Right.
But you've had to be extra resourceful because you've gone through some transitions recently, and specifically on the RCM team. Talk to me about that.
Yeah, the last 6 to 8 months have been quite interesting, for lack of a better word. In fall, we lost our CFO. And the team that was left, we had our billing manager and the billing team. And our billing manager quit shortly after, just about maybe October-ish. It was at the same time that Bill and our new billing manager were setting up a RCM optimization program with ECW. And the new billing manager came in, and she was literally, as I say, thrown into the deep end with weights on. Because when she got there and she started looking at the systems and the computer programs and information that the previous billing manager had, that computer was wiped clean. When she left, she wiped it out. I don't know why, it's proprietary information for the organization, but she wiped it out. So poor Winter, which was my new billing manager, was just like, what the heck are we gonna do?
In this case, a blank slate was not a good thing.
Not a good thing, nope, because she wanted to go into and see what she had done. The programs, how she do the checks and balances, all this stuff was gone. So she's like, okay, what am I going to do now? I'll step into the ECW RCM optimization team. They come in and to say, okay, we're going to help you through this, which you couldn't pick better timing at that point. They were able to come in and kind of go through the RCM cycle. If anybody's familiar with the RCM cycle, there's about 5 or 6 steps within there, from the initial presentation of the patient to the office, through the claims billing, claims submittal, payments, AR, and then the closing of the claim. And analytics too was on there, I forgot. So we, and I say we, I mean Bill and Winter, my former CEO and Winter, they worked with the team to kind of approach each section. Okay, how can you improve on each section to streamline things?
Okay.
And at every step of the way, there was insurance verification, which we went from I think a 70% insurance verification to 84% after the optimization program was done. And this is after we did some stuff with front-end optimization. We still improved upon that with that program. Claim submittals, especially denials of claims, which I found very interesting when I found this data, was my former billing manager always took pride in the fact that she would scrub every claim that came in, just made sure it was perfectly clean, because she liked zero denials, which I always said, you can't have zero denials. That just doesn't work in medicine. And found out that she was at about 40 to 45% denial. She would go back and clean them up, resubmit them, and submit to the board. That was zero, but she was at 45%. After the optimization, we went from 45% down to 17% denials,
wow,
which was phenomenal. Don't have the chart in front of me, but also with the payments, you saw a decline after she left of payments for the main part. That Winter was drowning in everything, but very fast rise back up within the month and a half after we started this, and our payments were higher than what they were beforehand. So denial rates were down, payments were higher, and I know since that time they've stayed pretty stable at those levels. So very, very good process for our whole organization to do.
I was going to ask about that. So the RCM process, as you said, has various clear steps in it.
Yep.
And it sounds like during the optimization process, you went and looked at each one of the steps and tried to find ways for improvement. Can you walk us through, like, how did the team go and identify what to even try to improve?
That's a great question. I think Winter was so blinded by the fact that there was just so many things to do. She didn't know where to start.
Okay.
And I think that the ECW team was really helpful with that, to come in and say, hey, we should probably do this, and this. And truthfully, I was not involved much in that RCM optimization, because they had their meetings on days I was seeing patients. So I really, patient care is more important. But Winter and I met and we talked over the last month and a half, went through all this stuff. And I learned a lot about the RCM optimization process, but they went through and there was just certain areas in each of these RCM sections, the cycled sections, that you could improve upon. Like I said, insurance verification when they check in, denial rates, you could watch that. You could go into the analytics, see where the denials are coming from, front office, mid office, back office. And truthfully, wizardry or whatever it is, they were able to go through and just each section had improvement. Each of the cycles of that RCM cycle had improvements on each of the sections. And I'm sure there's things in there that I don't even know about yet at this point, because I'm still on the learning curve of all that.
But it sounds like it was a nice combination of I'll call it personal observation, observing what the check-in and what that process was like, and also back-end analytics, just understanding, as you said, where the claims were coming from, who was denying them, and then obviously going back and looking at what systemic changes you can make to make sure those don't happen.
Exactly. And I think it's really talking to the people who are involved in that area, like the front desk. Ask, okay, what are your roadblocks? What is it that's causing grief for you? You can't sleep at night. Back office, that would be, again, the billing manager, Winter's aspects, and I know they had all sorts of problems. So, but they really knew where to go and look at, okay, how can we improve things? The rules engine, I think, was the biggest thing, where the team, ECW team, came in and set up these rule engines where things would follow and flow through automatically.
Okay.
That my billing team didn't have to do anymore. And I know, I've talked to Winter about this, that she automates so many things now that were manual beforehand. And it's so much easier for her. And again, our numbers just show that it's so much better than what it was beforehand. And I knew we could do that, but our former billing manager, had set in her ways, and you know how that is. They don't want to change much, and it's like, okay, fine. And so once she left, we had an opportunity, grabbed it, and it's been very positive.
I wanted to ask about that because the question I was going to ask you is, what are you doing now that maybe you weren't doing before? And, because of A, the technology, or B, because of your new process that you've implemented.
Absolutely. I think the biggest thing, which was what we stressed when I first got there, was we're submitting everything. We get the note done, the provider's done, it goes out. We don't sit there and scrub the claims. Everything goes out, and denials come back. We know denials are going to come back. It's just the nature of the beast with insurance companies. And again, the denial rate's 17% versus 42%. That automated and helped her so dramatically. Our billing team was pretty small and still is small, but they are able to handle things so much better. I think that was the biggest impact right there.
And on the flip side, what are you happy is in the rearview mirror now that you no longer have to do because you're on these new processes and these systems?
Let's see. I'm trying to think from my perspective.
Yeah.
The fact that we don't have a biller coming back and asking us, a provider, to change something constantly. And that's what, again, goes back to that former billing manager trying to clean each claim and clean each note so it came back as without a denial. We don't do that anymore. And it's sent out. And sure, we still have to change some things, but it's dramatically so much fewer numbers of charts.
Dealing with it on an exception basis, it sounds like, instead.
Exactly.
Okay. So what does having, at the end of this, like now that you have a, I won't say fully optimized, because it's never fully optimized.
Nope, never.
But now that you have a better RCM process, what is that allowing the organization to do as a whole?
I know for a fact that I've put a lot of pressure on my new billing manager to give me reports and give me some financial information, which before was very frustrating to get, and we didn't get a lot of the reports. She has now time to be able to do that, to run these reports. And they're more factual, more real time, whereas before they could have been a month, 2 months behind. And it's very hard to be retroactive with things like this. You want to be more proactive. So we're able to get this data sooner, and we're able to act upon it on, again, real-time basis moving forward.
What advice would you have? I mean, hopefully there's not many organizations going through what you went through and having your whole team disappear on you. But
God, I hope not.
but what advice would you have if someone does find themselves in a situation similar to what you found yourself in?
Think outside the box. I think sometimes people get into that narrow-mindedness, and that this is my world, nothing exists outside of that world. There are people out there that can help you, and they're really there to benefit your program. And bottom line is, benefit financially. Your organization's going to be able to come out ahead. FQHC world's tough to start with. We have a hard time getting payments. Our PPS rates are okay, but it's still tough. And this is very beneficial, being able to get some of that payment back in.
Where can people go to find more information about your organization?
www.hyndmanhealth.org. And I could spell it for you if you want to.
Please do, because I mispronounced it at the beginning. So
that's
please.
Okay.
Yeah.
It's H-Y-N as in Nancy. Let's see, Hyndman. I give you a think about it. D-M-A-N health.org.
Awesome. Dr. Stratta, thank you so much for being on our program and sharing all this great information with us today.
Appreciate it. Love doing this stuff.
Hey, if you enjoyed this interview as much as I did, we'd love for you to go check out more great content at healthcareittoday.com. I'm Colin Hung. Thanks for being with me on this video, and we'll catch you on the next one.